Dear doctors, so we're going to continue with the Mrcp basis consultation station, and today I'm going to talk a bit about the chest pain or patient has presented with stable angina. So as usual, let's start with our history. So this is a 60-year-old male accountant of Indian descent, and he complains of crushing central chest pain, which is radiating down both arms after running to the train station. There were no other associated symptoms, and he reports the pain was relieved with rest. Now remember that increasing age and male gender, these are the non-modifiable risk factors for coronary artery disease. So it is estimated that from the age of 40 onwards, each additional decade of life is associated with an approximately doubling of the risk of all vascular disease. And females are thought to have an approximately 20% lower risk than males. Now look at the profession of the patient. This patient is accountant, and accountant typically they have a desk-based job which can lead to an overall sedentary lifestyle. So this places them at risk of cardiovascular disease. So weekly exercises and activity should be explored further in the history. So also another important point is that the prevalence of coronary artery disease is higher in patients originating from the subcontinental population. Compared with Caucasian patients from the Indian subcontinent, they have a high prevalence of coronary artery disease. So the patient also said that pain is radiating down both arms after running. So this is the one of the three features of classic cardiac chest pain. It is suggestive ischemic heart disease. Angina is typically described more as a discomfort rather than pain. Other terms that can be used include squeezing, tightness, pressure, or maybe constriction, heavy weight on chest, etc. So remember that if it is a cardiac pain, it's not described as sharp or stabbing, and it should not change with respiration or position. Other features which are more typical of non-ischemic cardiac pain are the primary pain location, the mid or lower abdomen. Any discomfort which is reproducible by palpation or movement, fleeting pains lasting for a few seconds or less, and pain radiating down into the lower extremities or above the mandible. Typically, the angina is typically elicited by exercise or physical activities that increases the myocardial oxygen demand. So recreational drugs like cocaine can also trigger myocardial ischemia, and patients should be questioned about their use. Precipitation of chest pain by physical activity is another traditional feature of angina. Okay, just move on to our history. So his past medical history includes hypertension and diabetes mellitus, and both of which are treated with oral medications. The patient also had a significant family history of cardiovascular disease. Now remember that hypertension and diabetes, these are both modifiable risk factors of coronary artery disease, and the lifetime risk of developing cardiovascular disease is significantly higher among patients with hypertension. The target blood pressure for patient with diabetes is usually 125 to 130 by 80 mmHg as per the latest guidelines. However, the exact target still remains a slightly contentious topic. Remember that insulin resistance, hyperinsulinemia, and elevated blood glucose, these are all associated with atherosclerotic cardiovascular disease. So diabetic patients will typically have a greater burden of other cardiovascular disease risk factors such as hypertension, obesity, increased LDL, cholesterol, and hypertriglyceridemia. Now, um, In this patient also have a significant family history of cardiovascular disease, from which his mother passed away at the age of 63 years. Now remember that many family history is another independent risk factor for the development of coronary artery disease. So generally a positive family history is considered death from coronary vascular disease in a first degree relative before the age of 55 in males and before the age of 65 in female relatives. So on further questioning, the patient reveals he has previously had similar chest pain while walking, forcing him to stop for a short period of time, but attributes this to his poor fitness level. Now, so in this patient, chest pain that is reproducible when exertion, it is consistent with underlying ischemic heart disease. So it is important to question whether the nature of the pain has changed at all or the level of exertion required to induce it. Given that it occurs with a similar level of exertion as previously, so this makes acute coronary syndrome less likely, so more consistent with the stable angina. And normally, in PACES, obviously, you're not going to come across a patient of myocardial infarction. Most likely, you'll come across patient with stable angina. So that's all about the history. So in another important points in the history, always ask about the smoking history, alcohol history, social history. So these are all very, very important. You must take the complete history. Let's move on to the examination. So the patient appears comfortable and pain-free at rest. There is no evidence of increased work of breathing or diaphoresis on general examination. So increased work of breathing may reflect pulmonary congestion. It can be a sign of increased sensitivity of the underlying etiology, and diaphoresis is a sign that will be more concerning for acute coronary syndrome, and obviously it will warrant urgent workup and referral to cardiology if appropriate. He appears to have a large body habitus with a BMI likely in excess of 30. So obesity is a modifiable risk factor for coronary vascular disease. Obesity further strengthens the case for likely underlying coronary artery disease. This is an important feature that should be addressed in the management of this patient. Lifestyle modifications, they are always essential in preventing disease production. Reduction of weight will also assist in reducing the blood pressure and optimizing glycemic control in diabetes. The patient respiratory rate is 16 and BP is 155/90 and pulse is 80 beats per minute and regular. Obviously, pulse you're going to take in the examination, blood pressure pretest available, just take the blood pressure. Oxygen saturation 96% and the patient is afebrile. Now, remember that the patient is not hypoxic, which is also reassuring that there is no significant pulmonary congestion, and moreover, it makes a primary lung etiology less likely. Coronary vascular disease does not typically cause fever unless it is secondary to infective endocarditis. So if the patient was febrile, then other causes of chest pain such as community-acquired pneumonia would need to be excluded for the cause of the fever. So another important point is like arrhythmia such as atrial fibrillation may be present from atrial infarction, and this is reassuring. In atrial fibrillation, you would expect an irregular heart rate. Furthermore, the presence of AF with rapid ventricular response may also precipitate chest pain in patients with pre-existing coronary artery disease. And ventricular tachycardia can also result from acute MI, which would present with a far higher rate. Okay, so further examination, JVP is not elevated and Kussmaul sign is negative. The apex beat is not displaced or dyskinetic. So remember that JVP is typically increased with right ventricular infarction, leading to hypokinesis and poor contraction. And this leads to poor right ventricular filling and a raised JVP. The JVP being non-elevated is in keeping with the stable angina etiology. Briefly about the Kussmaul signs. Well, Kussmaul sign is a paradoxical rise in JVP on inspiration. or a failure in the appropriate fall of the JVP with inspiration. It is both a specific and sensitive sign of right ventricular infarction in patient with suspected inferior infarction, and it is also associated with constrictive pericarditis. So important negatives which you must mention in your presentation. Heart sounds are dual with no murmurs. So in severe coronary artery disease, an S3 or S4 may be auscultated. While S3, it can be heard in healthy young children and adults. It is typically pathological in patients who are more than 40 years and suggests a high left atrial pressure and increased left ventricular and diastolic pressure. So myocardial ischemia can lead to decreased myocardial relaxation and hence decreased left ventricular distensibility, and which can produce the S4 heart sound. So in heart sound, there is paradoxical splitting of the second heart sound. So remember, severe myocardial ischemia, it can lead to second heart sound being paradoxically split due to delayed relaxation of the left ventricular myocardium and delayed closure of the aortic valve. Auscultation of the lung reveals clear chest, and there is no evidence of peripheral edema. Listening to the lung, well, it is very important with any patient with chest pain or cardiac etiology because it provides vital information with regards to the fluid status and if there is any pulmonary congestion. Additionally, other respiratory etiologies can be included or excluded through a thorough chest examination, including auscultation of the lungs. So, the presence of peripheral edema, it will suggest that the patient is fluid overloaded. The causes of fluid overload are numerous, but in this case, you would want to exclude decompensated cardiac failure, which could be concerning for a large territory infarct. So, these are the important negatives which you must mention. Well, if you're thinking about the chest pain with cardiac etiology or patient with a stable angina. Let's talk about the investigations in this patient. So, 12-lead ECG show nil ST segment elevation or depression or new left bundle branch block. There is no T wave flattening or inversions. So, in stable angina, these are the changes which will be expected in the ECG. And remember, the ECG is definitely the most essential investigation, and it should be performed in all patients with chest pain. It is quick, it is non-invasive, and it should be completed as a priority. The absence of ST segment changes or new bundle branch block is reassuring that the patient is not having an ST elevation MI. Briefly about the T waves. Now, dynamic T wave flattening or inversion usually signifies myocardial ischemia and may be present in non-ST segment elevation MI. ST segment depression is another findings which is associated with non-ST elevation MI. So, with any patient with ST depression on ECG, it is important to closely examine for ST elevation and other leads and consider a posterior lead ECG to exclude a posterior stemming. What are the other things which we'll have to look on the ECG? There is, however, marked in this patient, we notice left ventricular hypertrophy meeting the Skolo-Leon criteria, which there is S wave depth in V1 plus R wave height in V5 is equal to 40 mm. So, left ventricular hypertrophy in this patient is likely due to poorly managed hypertension, so leading to remodeling of the left ventricle. Poorly managed hypertension generally increases the risk of the underlying coronary artery disease. We have, I already mentioned about this Skolo-Leon criteria, and these are commonly used criteria for diagnosis, left ventricular hypertrophy and ECG. And to meet this criteria, S wave depth in V1 plus Tallest R wave height in V5, V6 should be more than 35 mm. So serial troponins are performed, which are both within normal limits. Any patient with a chest pain, you like to do the serial troponins, and especially if you're thinking that the chest pain is likely cardiac, because they help delineate between an acute cardiac syndrome and stable angina, particularly in the absence of ECG changes suggestive of ischemia. What are the other investigations you like to do? Obviously, you want to do the chest X-ray, and in this patient, the chest X-ray demonstrate nil increased intestinal markings or overt consolidation. So, if there is increased interstitial markings, can sometimes be referred to as the fine reticular pattern, and acutely are representative of pulmonary edema or intestinal pneumonitis. The chest X-ray excludes significant pulmonary edema. So consolidation is any process that fills the alveoli with fluid, blood, or other substances. Usually, patient with pneumonia, they have a lobar consolidation. Diffuse consolidation is generally the result of a heart failure or over fluid overload from other causes. So typically in congestive heart failure, you will find bilateral perihilar consolidation with air bronchograms with increased interstitial markings. The cardiac silhouette is within normal limits. So typically in a patient with cardiogenic edema, there will also be increased heart size on chest X-ray. However, this is by no means a definitive relationship. What other investigation like to do? We like to do the urea electrolytes, and this patient results reveal a mildly raised creatinine of 10 mm and eGFR of 69. Hemoglobin A1C will be done for the patient was 6.7%. So the patient consequently undergoes stress echo testing, which was limited by poor exercise tolerance and was not definitive. There were some concerns regarding the anterior wall and anterior septum wall, but this wasn't confirmed. The study did not show any severe regional wall motion hypokinesis during stress. Now, with stress, the normal left ventricle becomes hypercontractile. Cavity size is small and ejection fraction increases. So the presence of new or worsening segmental wall motion with stress, it is suggestive of the presence of hemodynamically significant coronary artery stenosis supplying those segments. So based on the location of the hypokinetics or akinetic ventricle wall, the obstructive coronary artery disease can be localized. So in this case, the results were non-definitive, and given the strongly suggestive history, the decision was made to proceed straight to angiography. Okay, so no significant valvular disease was seen, and left ventricle ejection fraction was 60% estimated. So remember that during stress echocardiography, a baseline resting echo is obtained for comparison. The baseline echo also assesses gross valvular structure and function along with ventricular function, chamber size, wall thickness, and assessment of all segments of the heart. Aortic stenosis can also cause angina, and hence there is normal valve function. It can be reasonably excluded. Now, the patient has an ejection fraction of 60%. So this is a normal left ventricle ejection fraction. Typically, anything more than 55% is considered normal. And this is indicative that the patient does not have left ventricular systolic dysfunction, which can result from severe coronary artery disease and ischemic cardiomyopathy. So based on the findings from the non-invasive testing, the patient underwent coronary angiography with an estimated 65 to 70% stenosis of the mid left anterior descending and mild disease in the first obtuse marginal branch. So, coronary angiography is completed through radial or femoral arterial access, where a catheter is introduced into the heart to visualize the coronary arteries. 65 to 70% stenosis in the mid left anterior descending, along with mild disease in the obtuse marginal, is generally not considered significant enough for percutaneous coronary intervention. The only reason for PCI with the current finding would be failed medical management and ongoing symptoms interrupting the patient lifestyle. A decision for medical management was made for the treatment of this stable coronary artery disease. So, medical management entails pharmacological based therapies to reduce progress and treat symptoms. So, this we will be going to discuss later. Okay, now let's move on to the management. And again, I like to divide the management into the immediate management, the lifestyle, and long term. And finally, the prevention of the coronary artery disease. So, let's talk about the immediate management. So, acute symptoms management involves cessation of physical activity during the episode. Furthermore, to shorten the episode of angina, GTN in the form of sublingual preparation is first line therapy. While taking GTN, advise the patient to sit down, and it can be taken every 5 minutes up to a total of 15 minutes. If the pain persists past 10 minutes despite 2 doses of GTN, the patient should take a third dose and call an ambulance for urgent presentation to the emergency department. So, what does the GTN do? GTN actually dilates the coronary vessels, so allowing for greater flow through the stenosis and relieving symptoms. This will be not effective in ST elevation MI, which typically presents with total coronary occlusion. A side effect of the use of GTN is hypotension and orthostatic hypotension. So, therefore, the patient need to be educated regarding the importance of sitting down while taking the GTN to prevent a fall resulting from orthostatic hypotension. A trial of a single dose of GTN under supervision while the patient is asymptomatic can be considered so that they are able to recognize its effect. So, if the pain is unresponsive to GTN after 2 doses, it is concerning for acute coronary syndrome or other pathology causing chest pain. So, in this case, urgent presentation to the emergency department is required for detailed investigations and management. Okay, so let's move on to the lifestyle. So, risk factor reduction is a central component of managing patients with stable angina, and emphasis need to be placed on reducing modifiable risk factors. So, patients should be educated regarding cessation of smoking if they smoke and weight reduction. Education should be provided regarding increasing exercise and implementation of healthy eating. Help patients set up clear goals and targets for managing risk factors. And finally, patients should be advised to avoid heavy, sudden, and unaccustomed exertion and acute emotional stress. All patients with coronary artery disease should receive annual influenza vaccine. So, some points about the lifestyle management. So, smoking, is a modifiable risk factor for atherosclerosis in both coronary and non-coronary arteries. The incidence of MI is increased 6-fold in women and 2-fold in men who smoke at least 20 cigarettes a day. Smoking cessation, where it leads to a decrease in cardiac event range between 7 and 47%, and this is actually quite substantial. Obesity is associated with the number of coronary artery disease risk factor. It is associated with hypertension, insulin resistance, elevated LDL, cholesterol, and triglycerides. So, reduction in weight has been shown to reduce the annual cardiovascular event rate. So, diet factors that lead to increased CVD risk include high glycemic index, Diets: low consumption of fruits and vegetables, high consumption of red meat, high consumption of trans fatty acids, and low consumption of fiber. So exercise of even moderate degree has a protective effect against coronary vascular disease and all cause mortality. So remember that providing advice can be very easy for patient, but it is important to set reasonable goals so that the patient stays motivated. So education about the improvement in cardiovascular disease outcome by management of risk factors can be motivating for the patient. So one particular method of effective goal setting that can be utilized is setting up SMART goals. So by SMART we means S stands for specific, M for measurable, A is achievable, R is realistic, and T is for time related. So remember this SMART goals. There is substantial evidence that providing an influenza vaccine to patients with coronary vascular disease has benefit. Patients with coronary vascular disease have an increased risk for complications from influenza. Okay, so this is all about lifestyle. Let's move on to the long-term management. So the long-term management of stable angina is based on two core principles: anti-anginal therapy and prevention of disease progression. So let's talk a bit about anti-anginal therapy. For a patient with stable angina, beta blockers are usually used first line to prevent episodes of angina. For patient with left ventricular dysfunction, we use a cardioselective beta blocker. Non-dihydropyridine calcium channel blockers can be used as an alternative if beta blocker therapy is contraindicated. So cardioselective beta blockers, they include carvedilol, bisoprolol, nebivolol, or metoprolol succinate, and they have been shown to have a mortality benefit in patients with the heart failure, especially patients who have heart failure with reduced ejection fraction. Diltiazem or verapamil, they can be used as an alternative to beta blocker. Remember that never use diltiazem or verapamil in combination with the beta blocker, as it can cause severe bradycardia and can lead to heart failure. So a dihydropyridine calcium channel blocker such as amlodipine can be added to a beta blocker if angina persists, and a long-acting nitrates can also be added either to beta blocker or to a non-dihydropyridine calcium channel blocker. So if a combination of two anginal medication does not provide sufficient symptomatic relief, referral to a cardiologist is recommended. And nicorandil is another option for patient with refractory angina despite optimal therapy. So long-acting nitrates, actually they include transdermal glyceryl trinitrate and modified release isosorbide mononitrates. However, caution must be taken when these as tolerance to nitrate develop quickly. So to avoid this, ensure a period free from nitrate each day. This can be done by wearing the patch for 14 hours each day or using isosorbide mononitrate once daily. Remember, these long-acting nitrates, they do not improve overall survival. Okay. So then prevention of disease progression. So the following pharmacological regimes should be considered in all patients with stable ischemic heart disease: antiplatelet therapy like low-dose aspirin, high-dose statin therapy, antihypertensive optimization with strict target in hypertensive patient, glycemic control optimization in diabetic patient. Patient should also be referred to a cardiac rehabilitation program, and patient with chronic stable angina requires follow-up on a regular basis, 6 to 12 monthly follow-up. So if there is no contraindication, all patients should be treated with low-dose aspirin to reduce the disease progression. Clopidogrel is an alternative in patients who are allergic to aspirin. So remember, in all patients, regardless of the baseline LDL cholesterol, they should be treated with high-dose statin therapy if they have proven stable ischemic heart disease. Statins actually reduces the cardiovascular morbidity and mortality in patients with established cardiovascular disease. If LDL cholesterol targets are not met, additional lipid modifying medication may be required. So hypertension is an important modifiable risk factor that should be managed to the targets of 125 to 130 by 80 mmHg in patient with ischemic heart disease. In this case, the patient has a history of type 2 diabetes, they should be commenced on an AC inhibitor or ARB if they aren't already on it. So patients with stable ischemic heart disease who cannot tolerate metformin should be trailed on glucagon-like peptide 1 receptor agonist like liraglutide or sodium glucose transport inhibitors. SGLT, these are the new drugs, and they are quite effective in controlling the diabetes and also effective if the patients got the cardiac problem. Examples include like empagliflozin or canagliflozin. They have proven mortality benefit, in fact. However, the only issue with the GLP-1 receptor agonists is that they are administered subcutaneously, which can be issue with some patients. So remember that if the patient have heart failure with reduced ejection fraction, SGLT2 inhibitor, they should be strongly considered as it poses a significant mortality benefit on current evidence. Briefly about the cardiac rehabilitation, which is an effective means of educating the patient about a graded program of regular moderate exercise, and it is also an avenue for providing advice regarding other supports and services and assist in lifestyle modification. And finally, the follow-up is required to establish if there has been declining exercise tolerance, change in nature of the angina, medication compliance, and new adverse events, and to assess if sufficient effort is being made to modify the risk factors. Remember, these are all red flags and need to be monitored closely in all patients with stable angina. So that's all about the patient who has presented with a stable angina or stable chest pain. I hope this presentation is helpful to you. Thank you very much, and I'll see you in my next presentation.